تفضل. بسم الله الرحمن الرحيم. Welcome in this new CMA meeting of Egyptian Society of Nephrology and Transplantation. CMA meetings. This is the second meeting in Ramadan. Today we will discuss an important topic in regarding anemia management in chronic kidney disease, and we are honored to have our moderator, Professor Hisham Al-Sayed, the hemodialysis man of Egypt, Professor of Nephrology and Internal Medicine at Shams University. He is the head of Afran Nephrology. Nephrology. He is the head of hemodialysis chapter in Egyptian Society of Nephrology and Transplantation. Our speaker is Professor Kamal Okasha, Vice President of Tanta University. He is the Professor of Internal Medicine and Nephrology, Tanta University. Today, I was planning really to take this topic into two parts, including hemodialysis and chronic kidney disease. But upon our discussion with Professor Kamal this morning, he decided to take over the topic at all in this lecture and to take it one shot in this lecture, including iron therapy in chronic kidney disease, which will be much more better to have it in one lecture. And I thank Professor Kamal for his lecture today. Thanks, Professor Kamal. And I will leave the floor for our moderator, Professor Hisham Al-Sayed, to take over. Please, Professor Hisham, start.
Good evening, Professor, colleagues, and friends. It's a special day today. We have a very eminent, not only the speaker, Professor Kamal Okasha, one of the stars in hemodialysis and in renal nephrology disorders, diseases, CKD, and a lot of publications. We have also here a lot of very eminent professors, and I think the discussion will be very enriching. And we are looking forward for the illuminating talk from Professor Kamal Okasha. Professor Kamal Okasha, I think more than 30 years in the field of the nephrology, and so we have to listen carefully, and we have to make an attention for a lot of discussions that will be of value. Please, Professor Kamal, go ahead. We are all listening for you.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, dear Professor Yasser, for inviting me to give this talk in Ramadan. Actually, it's first meeting in Ramadan. And it's a real pleasure actually to be with you all, my professors and colleagues. And really, I feel very happy when I just been invited to give this talk today with you. Thank you very much, dear Professor Hisham, for this very kind words that you said in favor of me. And I'm a كلام كبير بس وش الحقيقة دكتور.
متعذر يا ريس، متعذر بكثير، تفضل.
الله يبارك فيك، وشكرا لكل الزملاء الأعزاء الحضور جميعا. أنا شايف كل الحضور. شكرا لحضوركم طبعا، وأسف مرة ثانية لتأخيري شوية عليكم، معلش أنا بعتذر. إن شاء الله I'm going to start now the topic. As Dr. Yasser said, it was supposed to be in hemodialysis, but I found all literatures actually are focusing on all dialysis and non-dialysis patients, and which is better actually just to cover the topic in this way. I will try my best to cover it in the respective times. If I think you give me half an hour or something, or if it's exceeding, you are very generous, and you are in Ramadan.
Mubarak.
كل سنة وأنتم طيبين جميعا.
Take your time, Professor.
Okay, thank you very much. I will just try to cover it in the proper time. As I said, the talk is going to be iron therapy and anemia management and chronic kidney disease patient, not only hemodialysis patient. As this is my agenda today, just to give a brief introduction about iron therapy and chronic kidney disease and initiation of iron therapy and oral versus intravenous iron medications. IV iron dosing regimen and formulation. And I will end by case scenario. It's a kind of basically kind of wrap up of what I said in one case scenario at the end. And of course, I'm going to finish with take-home message. Anemia, as you all know, is common among the patients with chronic kidney disease, and it's associated with poor outcome, including higher risk of death and poor quality of life. And iron deficiency is common and reversible cause of anemia among chronic kidney disease patients, and resistant to erythropoietin stimulating agent, is a resistance. The administration of iron is necessary for treatment of iron deficiency, and in selected patients may allow a higher hemoglobin in the absence of ASA. This is our agenda, main agenda for today, not to neglect iron from the start and go directly for ESA or something. So we have to just follow the classic scenarios that to start with iron if there is iron deficiency stores, and then you give erythropoietin. And these are the causes of iron loss in chronic kidney disease patients in effective gastrointestinal iron absorption, which is the classic scenario in all patients of chronic kidney disease, gastrointestinal or other bleeding. Can you hear me, right?
Yes, you are clear. Go, please, Professor.
Okay, because I've heard something here. The causes of iron loss in chronic disease, ineffective gastrointestinal absorption, gastrointestinal or other sources of bleeding, frequent blood testing, which is the case in chronic hemodialysis patient, and blood losses related to hemodialysis in every session. And this loss of iron can amount to a negative iron balance of 1.5 to 3 grams per year, and the effective erythropoiesis requires replacement of at least similar amount of iron. Regarding the initiation of iron therapy, first of all, before we start iron therapy, you have to have a kind of diagnosis of iron deficiency by what we call estimation of the iron stores by either serum iron, total iron binding capacity, ferritin, and calculation of the percentage transferrin saturation, and other methods, including, like, for example, percentage of hypochromic red blood cells or reticulocytic hemoglobin content, and bone marrow biopsies, which are considered the gold standard for diagnosis, but not commonly used among chronic kidney disease patients because of obvious reason. This may be not convenient to chronic hemodialysis or chronic kidney disease patient. And this table actually showing all kinds of tests that I have just mentioned, and with the strengths and weakness and limitation of each one of them. So I'm going, because for the sake of the time, I will leave the lecture for you just to read it, but it includes gold standard bone marrow, liver iron content, liver iron stores, serum ferritin, and so forth, and hepcidin also. So I will leave all of this stuff for you just to read it. And these are the markers of iron status in chronic kidney disease patient. Very briefly, serum ferritin, okay, of 100 to 500 microgram per liter in chronic kidney disease patient, and from 200 to 500 microgram per liter in hemodialysis patient. Transferrin saturation from 20 to 40%. Hypochromic red cell content or percentage of hypochromic red cells, which is considered less than 10% if the patient had sufficient or enough iron stores. Reticulocytic hemoglobin content more than 29 picogram per cell. Serum transferrin receptors, which is not established yet as one of the methods for diagnosis of iron deficiency, and the last one is erythrocyte zinc protoporphyrin, which also is not established yet. So now we'll go for the guidelines. In actual fact, the guidelines for anemia management, KDIGO has not been updated yet since 2012. And in actual fact, we are practicing the same since 12, even if there is some other news from NICE or whatever, or optimization, or like kind of reappraisal, but still the same as we follow in the clinical practice. For example, this is for the KDIGO, treatment of iron with iron agent when prescribing iron therapy balance the potential benefits of avoiding and minimizing the blood transfusion is a therapy and anemia related symptoms against the risk of harm in individual agent, for example, anaphylactic shock and other hypersensitivity, which is considered more or less not graded. For adult chronic kidney disease patient with anemia, not on iron or ESA therapy, we suggest trial of IV iron. Or in chronic kidney disease patient, non-dialysis patient, alternatively 1 to 3 months of oral iron before starting IV. And an increase in hemoglobin concentration without starting ESA treatment disease, and TSAT less than 30% and ferritin less than 500 nanomolar. So these are the criteria according to the KDIGO to start iron therapy. I think we are talking the same theme actually for the sake of the time. I'm not going just to repeat. So it's basically mentioned that the guidelines of KDIGO in terms of iron therapy to achieve the target of the TSAT of around 530% or ferritin of around 500, and to start other ESA not before starting or reaching this target actually. Again, the same. These are iron status evaluation, and very cautious regarding the iron therapy when the initial dose of intravenous iron dextran, for example, which is still very common, actually, and is still used with caution. As I said, this is graded 1B, one recommendation 1B. So it's strong recommendation when initiated the initial dose of iron, non-dextran iron is administered. We suggest, according to the KDIGO, we suggest the patient to monitor for 60 minutes after the infusion, and that أنا ممكن excuse me, can I take this picture down؟ مش عارف تقدروا تنزلوها لي ازاي. I can minimize. Okay. For non-dextran iron administration to monitor the patient for 1 hour or half an hour after the infusion, and that resuscitative facility, including the medication in terms, for example, corticosteroids, and trained to evaluate and treat serious adverse effects. So it's very important not to give intravenous iron like this. So we have to make this to do and monitor the patient for. Can you hear me?
Yes, Professor Kamal. If you can get a good, better connection, will be much more better.
Okay. So if you have to have kind of testing for hypersensitivity testing for the iron therapy before iron therapy giving, and just if the patient is fluoritic, you can continue the infusion. And iron during the injection, avoid administering during infection, avoiding administration of intravenous iron to patient with acute or systemic infection, although it's not graded, but it's very logic and very valuable. Again, iron is recommended to most of chronic kidney disease patients who have TSAT less than 20% and serum ferritin less than 100 nanogram per ml, and such patients are likely to have diseased or decreased iron stores, absolute iron deficiency. And although most of the chronic kidney disease patients with TSAT of 20 to 30% and ferritin of 100 to 500 will have normal iron stores on bone marrow, which is, as I mentioned, is not common to our patients. Yeah. Although most of the chronic kidney disease of 20 to 30 and ferritin of 100 to 500 will have normal iron stores and on bone marrow biopsy, many will respond to iron with the increase in the hemoglobin or decrease in the erythropoietic stimulating agent. So this is one of the advantages actually of iron, was to minimize the dosage of ESA dose. This is I'm going to mention later in dosing of the dosage of the iron therapy. Again, iron therapy patients are not treated with iron therapy who have TSAT more than 30, since such patients are unlikely to respond to iron. Okay, and again, also don't routinely give iron to patients with ferritin more than 500 nanogram per ml. Although each patient should be individually assessed, and I like this word actually. Every patient should be individualization of everything, like Dr. Hisham is a well-known figure of nephrology and hemodialysis. He used to have this word individualization or personalization in every patient actually. And this is a patient, not every measure or one fit doesn't fit alone, one measure doesn't fit all. So it's very important actually to go for every patient individually. And I like that word actually from Dr. Magdi. I don't know if he's around or not. I'm treating a patient, I'm not treating a numbers. As an example, some patients at high risk of iron deficiency, such as those with chronic gastrointestinal bleeding, will have TSAT less than 20 and may have a ferritin of more than 50. So yeah, which is just, we're going now to talk about which kind of deficiency. It's relative or true deficiency. So this is one of the typical examples of the relative deficiency, that is TSAT less than 20 and ferritin more than 50, 500. Well, for example, because of of course, infection is very important issue in this matter during treatment of patients with iron deficiency, anemia, and the deficient stores to differentiate between the true and relative deficiency. The goal of iron therapy is to correct absolute iron deficiency and also increase hemoglobin level to that desired level in that patient, particular patient. We generally provide sufficient iron to accomplish this while attempting to maintain TSAT less than 30%. And some patients will not increase hemoglobin to the desired value despite of achieving the TSAT approximately of 30. Such patient may be candidate for treatment with ESA. So if you reach the target and the patient did not achieve the hemoglobin level, then we start ESA therapy. You can just excuse me for these basic issues actually before going directly to the types and initiation. And iron indices should be re-evaluated after therapy, typically 1 month after the dosage following intravenous, and every 3 months during the patient receiving oral iron. And for patient treated with oral iron, we usually switch to intravenous iron if iron status tests and hemoglobin are not improving and remain low below the goal. And iron indices generally respond to intravenous iron therapy. Patients who do not achieve the target TSAT and ferritin or at least show significant improvement in the iron stored despite intravenous iron be evaluated for other sources of blood loss. It's very important actually to consider blood loss in patients, not even while you are giving iron, but the patient is not responding. You should think about iron loss from whatever sort, basically the gastrointestinal loss. So which formulation we have, or we prefer oral versus intravenous iron. الحقيقة طبعا يعني في many studies tackled this issue, ولكن this just from the guidelines, the KDIGO guidelines does not recommend the use of oral iron in chronic kidney disease stage 5D, I mean patient on dialysis, but suggest either oral or intravenous iron may be considered in chronic kidney disease non-dialysis patient, and the route of administration is selected based on the severity of the anemia and the iron deficiency. Patient ability to tolerate oral iron, the response to prior oral iron therapy, history of adverse reactions, or intravenous iron, and primary availability of the venous access. Regarding the oral iron presentation or formulation, the current one, which is the very common ferrous sulfate, 325 milligram 3 times daily. Ferrous sulfate provides 65 milligram elemental iron per 325 milligram tablets. Ferrous sulfate should be given between meals if tolerated. Intestinal absorption, iron absorption may be normal or impaired in patient with renal failure and may be reduced by the blood, by food or antacids. And giving one of the doses at the bedside may be a very simple and effective method for giving iron. And I myself, I prefer giving the dose at night actually, because to avoid the gastrointestinal upsets. Rather than ferrous sulfate, there are multiple other agents are available, but tend to be more expensive actually, without greater efficacy or consistently fewer side effects. As example, for example, ferric citrate. I'm not going to take too much about it, but ferric citrate has a special case actually. It's used as one of the iron therapy for anemia and one of the iron therapy actually for hyperphosphatemia. Heme iron polypeptides, actually liposomal preparations. These all are forms that we may have or we don't have in our clinical practice, at least in Egypt actually. So, but I have to mention all the varieties for those who may be living around, actually they may have these issues and they may be referred to be one of the methods of oral administration of iron. Oral iron does not require administration of in a healthcare setting. مش محتاج يدخل مستشفى علشان ياخد. فده very simple and very convenient to the patient with chronic kidney disease, non-dialysis, and the preservation of the vasculature to allow the creation of AV shunt. Oral iron also is widely available and inexpensive. These are advantage of oral iron therapy. So again, oral iron does not require administration to hospital, for example, and to preserve the vasculature, the vessels for the AV shunt, and oral iron is widely available and not expensive. These are the advantage of oral iron therapy. So what are the disadvantages of oral iron therapy? Oral iron therapy imposes a high bill burden. بيزود عدد طبعا الأقراص اللي بياخدها مريض الكلى with a typical regimen of 200 milligram elemental iron per day. محتاجين ندي كتير قوي علشان نوصل يوصل العيان للثيرابيوتيك دوز اللي احنا عاوزينها. فطبعا ده هيزود الاورال bill burden على العيان. And he may suffer a lot. Both the high bill burden and unpleasant side effect associated with oral iron therapy can lead to adherence issues, and it may ultimately limit efficacy as well as patient quality of life. And it should also be considered that anemia is associated with reduced gastrointestinal absorption of iron. Uremia, is associated with reduced gastrointestinal absorption of iron, while chronic inflammation and medication interactions can also impair the gastrointestinal iron uptake. So these are another obstacle for oral iron administration. There are a number of options available for treatment with an intravenous iron preparation. We generally do not use the iron dextrose for its very bad side effect actually which is very well known to all of the others, but again, it's still used actually in a wide range. And oral iron dextran is associated with high incidence of serious adverse effects, particularly anaphylaxis, than iron saccharose or saccharose complexes. Other intravenous iron preparation, including these are newer agent, ferromoxitol, actually, and iron saccharose, ferric gluconate, saccharose complex, and ferric carboxymaltose, which is, I mean, we don't have it in Egypt, actually, but the data around ferric carboxymaltose is very promising and showing that it's very efficient and less side effect. All of these products are equally effective in treating iron deficiency, and the major differences include cost, formulary purchasing agreement, and the number of visits per time required to administer the full dose. If you want to just to achieve the target, you may need 5 injections or something. So it's based on which one you can give in single sitting, for example, or double or couple of sittings. The frequency of serious side effect events is comparable among the products. The ability to give large dosage of oral iron, for example, up to 1,000 at one administration, and the number of required intravenous cannulation can be limited actually with intravenous iron. So, but just to remind you again, for the testing dose before giving the iron therapy to avoid the anaphylactic reactions and serious adverse side effects. So again, hypersensitivity potential, oxidative stress is also and risk for infection because of intravenous administration of iron bypass physiologic controls over the absorption from the gastrointestinal tract from the gut. It has been suggested that the long-term use of intravenous iron could result in deposition of iron in the liver, pancreas, and heart, and ultimately resulting in organ damage. So we have to be careful, very careful of that, and you have to manage, and you have to just monitor for the serum. Have to monitor for the serum iron stores actually every now and then. For patients who require more rapid repletion of iron or more or are unlikely to be effectively treated with oral iron, including most patients with symptomatic anemia, severe iron deficiency, severe anemia, risk of ongoing blood loss, and history of side effect to oral iron, history of not responding to oral iron. So these are the indications for intravenous iron administration. And this study actually shows randomized controlled trials comparing the intravenous iron saccharose to oral iron in anemic patients with non-dialysis dependent chronic kidney disease, and showing that the cumulative response percentage of patients achieving the hemoglobin target, I mean 1 gram per deciliter or greater, is more and much significant with patients receiving intravenous iron. And similarly, the hemoglobin change, delta change of hemoglobin in patients receiving the intravenous is much greater than patients receiving oral iron preparation. And the conclusion of this study is that intravenous iron administration using 1,000 milligram iron saccharose is divided is superior to oral iron therapy in management of non-dialysis chronic kidney disease patients with anemia and low iron. Again, this is another randomized controlled study of iron supplementation in patients treated with erythropoiesis. And again, that the result of this study suggests that even in iron-depleted patients, those supplemented with intravenous iron have enhanced hemoglobin response to erythropoietin with better maintenance of iron stores and lower dosage of requirement of EVO compared with those patients receiving oral iron and even non-iron supplementation. Even in patients who are iron related, if you give a small dose of iron to enhance the hemoglobin response to EVO. Again, this is another study which is published in Foreign Clinical Practice, comparing the intravenous iron saccharose to oral iron in the treatment of anemia patient on chronic kidney disease. And this is the result, or almost the same, although the result, is an old study showing again that intravenous formulation is better in chronic kidney disease patient, non-dialysis patient. So this is another study showing the effect of ferric citrate in patients with non-dialysis dependent chronic kidney disease and iron deficiency. And in actual fact, it's comparing both, just allow me, it's randomized controlled study showing the effect of ferric citrate versus placebo. This is oral to oral, basically. Randomized study comparing the ferric citrate to placebo, and the results showing that during the initiation phase, actually the ferric citrate is much better than the placebo, and in the extension period, which is the other side of the graph, showing also the ferric citrate is superior to the placebo for treatment of anemia chronic kidney disease patient, non-dialysis patient. And again, this is showing the percentage of the patient responding to treatment in the ferric citrate. It was 52% of the patient compared to 19% of patients receiving placebo. So this is another advantage actually of ferric citrate in terms of raising the serum transferrin saturation, raising the ferritin actually, and again also it has an impact on the parathyroid hormone and fibroblast growth factor from. This is if we just effect of ferric citrate on the other side of the scene, which is hyperphosphatemia. The effect of ferric citrate on hyperphosphatemia is associated with low parathyroid activity and low fibroblast growth factor 23, which is another advantage of ferric citrate. And this is an update on adverse drug events associated with parenteral iron. And this conclusion of this study is the frequency of intravenous iron-related adverse side effect actually, or adverse reactions reported to the FDA has decreased, and overall the rates of are extremely low. And this is a fourth report suggesting the increased risk of associated with the provision of higher molecular weight iron dextran. As long as you're away from the dextran, you are safe. Again, this is another meta-analysis for the safety of intravenous iron preparation, and this is a systematic review and meta-analysis. This meta-analysis actually, which from 5,340 record, يعني after exclusion and rolling out, صفي في الآخر على 103 study, including the questionnaire of the meta-analysis. والحقيقة يعني كان الكونكلوجن بتاع الميتا اناليسيز and systematic review that intravenous iron therapy is not associated with an increased risk of serious adverse event or infection. Infusion reactions are more pronounced with intravenous iron. اوكي طبعا، ولكن مع ايه بقى؟ زي ما احنا قلنا بنأكد مرة ثانية مش كل الانترافينوس ايرن هم اللي مسؤولين عن الكلام ده. وده برضو another meta analysis برضو، والconclusion بتاعنا اللي هو from 24 trials were identified 13 including كم عيان؟ حوالي 2400 عيان with chronic kidney disease 3 to 5 stage 3 to 5 and 11 including 800 patients with chronic kidney disease. الحقيقه طبعا ده برضه بيأكد مره ثانيه ان احنا we don't have to analysis showed similar rates between mortality and serious and any adverse event event effects. Intravenous iron replacement was associated with high risk of hypotension. برضه بنأكد تاني ده مش مع كل الانواع الايرن، مع selected types only اللي بتعمل الكلام ده. Our result with current recommendation for دي الداتا اللي هي بتاعت الميتا اناليسيز اللي احنا قلناها ده suggest that this for recommendation for intravenous iron replacement for patient with chronic kidney disease stages 5B and support the increased use of intravenous iron for patient with chronic kidney disease even stage 3 to 5. لو كان فيهم الكرايتيريا اللي انا قلت عليها they are not responding او في intolerant to oral iron and we want to achieve the target level for the patient to receive the isotherapy. And now I'm going to talk about the intravenous iron dosage regimen and formulation. والحقيقة there are lots of iron intravenous iron preparations that we have in the market. ولكن ده التيبل ده طبعا as I mentioned I'm going to leave the lecture for you. So في عندنا انواع كتيره قوي زي مثلا اللي هو الصوديوم فيريك جلوكونات، اللي هي الايرن سكروز، الفيريك كاربوكسيمالتوز وده واحد من النيور ايجنت actually and low molecular weight dextran and iron isomaltoside and fermoxytol ده برضه واحد من النيور ايجنت، ولكن مشكلتهم اللي هو الكاربوكسيمالتوز والفيرومكسيتول are very expensive actually. والحقيقه احنا still we don't have them in Egypt actually. ولكن عندنا اللي هو الدراجز اللي هو الانترافينوس اللي هو commonly we are practicing اللي هو طبعا اللي هو الايرن سكروز والايرن ديكستران. ولكن يعني لازم نخلي بالنا واحنا بنستخدم الايرن ديكستران اذا كنا هنستخدمه اجين، يعني معلش باكد عليها مره واثنين وثلاثه لشبابنا الموجودين اللي سمعنا، نشكرهم طبعا على ان هم سهرهم معانا النهارده. والحقيقه الانواع الثانيه اللي موجوده we have to be aware يعني اكيد at sometimes may have this medications in Egypt actually, so we have to have a hint about it and how to use it like this. So as I mentioned, I'm going to leave this talk for you, so including all the preparations and the formulation and the way to give like that. Again طبعا ممكن نوضحها في التكست ده اكتر. في الموكسيتول is preferred dose بتاعته 510 مللي جرام دوز، ده دوز واحده وخلاص تقريبا، يعني followed by a second milligram dose 3 to 4 days after the first dose and although some prescribe a single dose of 1020 milligram dose, the doses are usually sufficient to replace iron. دي الميزه في الدراجز الجديده دي او في الايرن بريبريشنز الجديده انها استخدامها ممكن يكون سنجل تايم تمام or maybe 2 doses لو احنا احتاجناها. الايرن سكروز طبعا احنا عارفين ممكن نديه over 2 weeks، ممكن نديه 5 doses زي ما احنا عارفين ال 1000 مللي جرام نديهم اوفر كل جلسه، ممكن ندي على الغسيل 1 or 2 امبولز مع كل جلسه، وعلى مدار اسبوعين هنكمل اللي هم اللي هو ال 1000 مللي جرام. الكلام ده على الدياليسيس بيشنت. طب هاو اباوت نون دياليسيس؟ ممكن نديها انترافينوس نورمال سيرين طبعا، بس خلي بالنا برضه احنا بندي ناكد على موضوع التست دوز. Ferric gluconate, the preferred dose is 250 milligram once weekly for 3 to 4 doses. Ferric carboxymaltose ده اللي انا بتكلم عليه برضه، نخلي بالنا من الحاجات ديت مهمه قوي. Ferric carboxymaltose 2 doses of 700 milligram may be given in 1 week. And isomaltoside برضه isomaltoside may be given in a single dose also of 1000 مللي جرام. والايرون ديكستران نخلي بالنا برضه مهم قوي. هو الايرون ديكستران مهم قوي في ميزه ان انت لو عملت تيست دوز والبيشنت طلع ما عندوش هايبر سنسيتيفيتي يو ماي جيف اللي هي التوتال دوز ان سنجل تايم سنجل انفيوجن. وزي ما انتم شايفين بنعمل 25 مللي جرام تيست دوز is generally well tolerated. How to do it ال 25 مللي جرام. الموضوع في منتهى البساطه، بتاخدهم بتدي على ربع ساعه او على ثلث ساعه اللي هي 25 مللي جرام، او بتبدا 25 تتكمل بعدها على طول لو البيشنت didn't show any side effect or any kind of adverse reaction like hypersensitivity or so. The newer ميزه الانواع الجديده بقى، ميزه الانواع الجديده عشان كده احنا بنديها مره واحده او مرتين. The newer more stable iron complexes like fermoxetol or ferric carboxymaltose or isomaltoside don't readily dissociate under the physiologic condition, whereas less stable complexes like iron saccharose or sodium ferric gluconate dissociate easily. وعشان كده الهاف لايف بتاعتها very short and we need to over 2 weeks.
استنى.
Okay.
Okay, go ahead, Professor Kamal.
Okay. Thus, for patients with chronic kidney disease, non-dialysis patient receiving intravenous iron or high dose of low frequency schedule, the use of more stable formulation would be very appropriate and very convenient to patients with chronic kidney disease with stage chronic kidney disease 5 اللي هم على dialysis receiving frequent low doses. هيبقى اكثر احسن ليهم قوي ان هم ياخدوا سنجل دوز مره واحده. less stable formulation other formulation طبعا اللي هي زي الفيريك سيتروز او الجلوكونيت. لا في الحاله دي نفضل لو في available formulation زي ده with stable iron complex. لو available طبعا هيبقى very convenient and very effective. ممكن اتكلم شويه على الفيريك كاربوكسيمالتوزايد versus oral iron in patient with non-dialysis patient. This analysis over 1 year actually the conclusion بتاعنا as a result of this study showed further further support for the conclusion that the correction of iron deficiency stores with intravenous ferric carboxymaltose is safe in patients with non-dialysis non-dialysis dependent chronic kidney disease. Again, regarding the selection of the iron preparations, actually this is comparative study of various intravenous iron preparation in chronic kidney disease. ودي واحده برضه من الاستادي اللي قارنت عدد كبير جدا من انواع الفرايتيز اوف ايرن، وكان طبعا على عدد حوالي 400 عيان تقريبا استخدموا ايزر ايرن ستران فيريك كاربوكسيمالتوز ساكاروز. وكان الكونكلوجن بتاعنا بتاع الاستادي دي it was observed that the total number of adverse effects especially serious adverse effects is significantly less effective in non-dextran formulation. ده طبعا بنكونفيرم مره ثانيه وبنأشور مره ثانيه على ان الاذر varieties are safe. ولكن برضه الدextrose if you still have to use it you have to, if you still have to use it actually you need to do test dose and to continue if the reservation doesn't have adverse effects. And this is another randomized comparison of fermoxetol and iron saccharose for treatment of iron deficiency anemia in patients with chronic kidney disease. And the conclusion in this randomized controlled trial fermoxetol and iron saccharose showed comparable efficacy. خلي بالنا برضه احنا الكلام بتاعنا بالنسبه للنيور دراجز مش عشان الافيكاسي بتاعها، دي طبعا دي randomized controlled study كبيره ومنشوره في الامريكان جورنال امريكان سايت اوف نفرولوجي في الجسم. وبتاكد مره ثانيه برضو ان احنا مش الفكره افيكاسي، الاثنين ار مور افيشنت، ولكن الفكره في الايه؟ في الكونفينينس اللي هو الفريكونسي اوف ذا دوزج اوف ذا ميديكيشنز. طبعا الميديكيشن دي افيلابل فور شور هتبقى مهمه جدا لينا وهتبقى مور كونفينينت لينا وللمريض. Intravenous iron dosage regimen and formulation again regarding the selection of the iron. Okay, is intravenous ferric carboxymaltose versus standard medical care in the treatment of iron deficiency anemia in patients with chronic kidney disease, a randomized active controlled multi-center study, the conclusion that ferric carboxymaltose dose of 200 milligram for hemodialysis chronic kidney disease patient and up to 1,000 milligram in non-dialysis dependent chronic kidney disease patient were well tolerated and displayed comparable effect of the efficacy with the other formulation. يبقى برضه this is another evidence بيأكد على الافيكاسي بتاع الاثنين حتى مع the newer agent الافيكاسي is the same ولكن يهمنا القصه بتاعت الايه؟ الفريكونسي اوف ذا ميديكيشن. وده برضه من كلام تاني مهم برضه beyond the consideration of the efficacy and effectivity which is at least among non-dextran formulation are largely equivalent. The selection of iron and intravenous iron formulation is also driven by the availability. يعني على حسب الدواء موجود ولا لا، زي ما هو موجود مثلا السيناريو عندنا في مصر ان الدواء ده مش موجود يعني خلاص ما استخدموش، لا استخدم ادور على another convenient agent موجود في مصر. احنا يمكن انواع جديده دي مش موجوده في مصر عندنا، او برضه تفكروني اساتذتنا لو كانت available or not. But as far as I know it's not available yet. And some formulation are only available in specific geographic regions while cost برضه is still هتبقى barrier في البريسكريبشن. يمكن هنتكلم بقى يعني برضه على قصه احنا قلنا اتكلمنا على كلام الفريكونسي والافيكاسي والكلام ده. هنيجي لانذر ايشو مهم جدا اللي هو ايه؟ البيفوتال ترايل. البيفوتال ايرن ترايل دي واحده من ضمن الاستاديز المهمه جدا اللي هي يعني طبعا كانت حصل زي اناونسمنت عليها في البدايه في النيو انجلاند جورنال اوف ميديسن. كانت ده في بدايتها في سنه 2019 والاستادي استمرت for 2.5 years على 2140 عيان. وكان العيانين بتوعنا يتقسموا لتو جروبس. patient received high dose of iron saccharose were prescribed اللي هو بيسموه high dose group and the other group were prescribed اللي هي low dose iron from 0 to 400 milligram of iron saccharose monthly. وكان الهدف من بتاعنا ان احنا to achieve that اللي هو التي سات more than 40% in the high dose group and to more than 20% in the low dose iron group. يبقى احنا again الاستادي اتعملت على حوالي 2140 عيان استمرت لمده حوالي 2.5 سنين. ودي من الاستاديز المهمه جدا على فكره برضه regarding the iron dosage. وهنقول البنفيتس بتاعتها دلوقتي كانت ايه على مدار السنتين ونص اللي لاحظوهم during this study. كان الهدف ان احنا to achieve the target بالنسبه للهاي دوز جروب اللي هم بيريسيف 400 ملغ ايرون ساكروز بالتي سات مور ذان 400 او اللو دوز جروب اللي هي كانوا المفروض ان هم ياتشيف اكثر من 20 ملغ 20% of TSAT or more than 200 ملغ فريتين. بالمناسبه برضه بالنسبه للهاي دوز جروب الفريتين كان التارجت بتاعنا 700 ملغ، ولكن ده طبعا يعني مش ما بنوصلش ليه عاده. لو وصلنا ليه we should discontinue الايرن بريبريشن لو وصلنا لكده. فاحنا هنشوف يعني the benefits of high versus dose. هو طبعا اللي هم لاحظوه في الاستادي دي ان دوز ايرن جروب كانوا مور superior عن الاذر لو دوز جروب. وكان واضح هنا من الريزلت بتاعتنا the high dose intravenous iron administered proactively بيسموه proactively was وده من كلمه اللي هي البايفوتال proactive iron in hemodialysis patient were better than the low dose course administered reactively. يعني مش عاوزين احنا نبقى reactive بمعنى اصح. There was significant reduced risk of death, hospitalization and heart failure and other major non-fatal cardiovascular event and no increased infections. ده كان مع الهاي دوز intravenous dialysis patient intravenous iron patient. Other additional benefits in the high dose group يمكن تستغربوا بس هو ده اللي حصل بالفعل، وديت الداتا اللي واضحه بالفعل واللي هتتنشر في النيو انجلاند جورنال اوف ميديسن. اكيد الداتا بتاعتها قويه جدا انها فعلا تتنشر ايرلي، الانونسمنت بتاعها يبقى ايرلي، والداتا بتاعتها هتتنشر بعد كده في النيو انجلاند جورنال اوف ميديسن وفي اذر جورنال اللي هو الجاك اللي هو الجورنال اوف امريكان كولج اوف كارديولوجي. الداتا بتاعت الكارديولوجي دي كلها من الجاك فروم ذا جاك جورنال. ايه تاني؟ ريديوسد اللي هو الاريثروبويتين دوز ريكوايرمنت، وده حاجه مهمه تفيدنا كتير. احنا طبعا يعني الناس بنسفر من قصه الاريثروبويتين والكوست العاليه بتاعته، ولو احنا استخدمنا الايرن بريبريشن بالطريقه الصح فعلا ممكن يبقى احنا عندنا ريديوسد اللي هو الايبو دوزج ريكوايرمنت and this could be beneficial as high dose of EPO has been. وبرضه حتى كمان الهاي دوز اوف ايبو مش بصرف النظر عن الكوست كمان is being associated the high dose of EPO is associated with increased risk of cardiovascular events such as stroke. احنا طبعا اكيد يعني عارفين الداتا الكتير اللي اتعملت على الموضوع سواء الكوير او الكريات او التريت ستادي for this issue in large dose of EPO. In addition to fewer blood transfusion, also this is one of the advantage or the benefits of this study, that there was or there were fewer blood transfusions and reduce the risk of developing antibodies against لو احنا بنفكر to transplant this patient and to have successful transplant to avoid the blood transfusion, of course, as you all know. And this is very a brief case scenario actually from the data that I have mentioned regarding the frequency and the dosage. This patient, 62 years old, female, prescribing with IgA, glomerulonephritis, and estimated GFR of 18 milliliter per minute, was found to have hemoglobin 88 gram, يعني 8 جرام 8.8 جرام per deciliter, with serum ferritin 112 milligram per liter and TSAT of 14. The C-reactive protein was measured يعني كان average ما كانش high، معناه ان ما فيش infection، and ESR was not elevated. فكل الكلام ده معناه ان فعلا there was definite true iron deficiency. Based on the evaluation of the serum ferritin and TSAT, the benefit the patient has deemed to be iron deficient, and the initiation of iron therapy to correct this deficiency was the first priority for the physician. عشان نبدا الإيزا طبعا كان هيبقى مش مناسب خالص ان احنا تبدا إيزا ثيرابي in this patient with deficient iron stores. Therefore, we have to start or iron preparation. For in this instance, the patient was not being seen in a healthcare setting on a frequent basis. فكان برضه كان صعب ان هو يروح المستشفى كتير، فكان اضطر طبعا according to the KDIGO تمام ما عندناش اي سايد بتاع ده موانع ان هو ممكن يبدا الاورال ايرن، فالبيشنت بدا ترايل اوف اورال ايرن. however follow up after 4 weeks بعد شهر زي ما احنا قلنا في الفولو اب بتاعنا بتاع العيانين على الاورال بعد شهر اللي هم ال4 weeks revealed that the patient had stopped taking the oral iron due to diarrhea. يبقى فيه intolerance gastrointestinal side effect. Although the patient had significantly slightly increased to 122 ما زادش كتير زي ما احنا عاوزين وما وصلش التارجت بتاعنا، وتي سات فضل قليل حوالي 13 اللي هو كان تقريبا 14 بالعكس بيقل. ده بيشنت ما هوش كانديديت فور اورال ايرن. سو نعمل ايه؟ طبعا we have to خلي بالنا احنا طبعا البيشنت ده ما بيقدرش يروح المستشفى كتير، صعب ان هو يزور المستشفى، صعب ان هو to be seen frequently. فعشان كده الاورال ايرن مع الرغم من ان هو سهل وطريقه بسيطه جدا وفيري كونفينينت ليه، الا انها طبعا بينت ان العيان ده is intolerant and he has to be shifted to intravenous iron was necessary عشان to achieve the iron store or to replenish the iron stores. يمكن ارجع اعيد تاني برضو وافكر قبل السلايد اللي جايه، ولو حضراتكم يعني رجعت الكلام ان احنا بنأكد على الفريكونسي وعلى الدوز وعلى حاجات كتيره قلناها في الفتره اللي عدت، وكومبيرنج اللي هو الانواع اللي احنا عارفينها اللي هي الستيبل برودكت اللي هي الايرن كومبلكسز very stable to the less stable one So we prefer the stable one لأنها طبعا بنديها على wide interval or long interval. ممكن مرة كل يوم، مرة كل شهر ولا بتاع. طبعا كتير يعني دي محتاجين احنا نوع زي كده في العيان بتاعنا ده اللي هو عنده مشكلة في ان هو to visit the hospital very regularly. فعشان كده لازم محتاجين نوع من الانواع اللي هي العيان اللي مش محتاج ان هو ياخدها very frequent. زي for this non-dialysis patient we use the use of ferric carboxymaltoside. تمام. hopefully ان شاء الله يكون موجود عندنا. تمام. Ferric carboxymaltose is a newer and more stable formulation that's approved in a single administration up to 1,000 in patients with chronic kidney disease non-dialysis, avoiding the inconvenience of more frequent visits to the patient to the hospital. After 2 months, serum ferritin and TSAT had increased to 467 milligram per liter and 28 respectively. المهم ان احنا وصلنا للتارجت يعني more or less قريبين منه قوي. ممكن لو كملنا كمان سنجل دوز ولا حاجه كمان ممكن نوصل للتارجت بتاعنا of more than 500 ferritin or التيسات 30. ولكن انا اعتقد ان الرقمين الاثنين دول يعتبروا very convenient to achieve the target of the iron stores. At this point, sufficient iron store to support its effective use, and ISA اللي هو الإبوتين ألفا was initiated in a dose of 4,000 international unit 3 times weekly, and after follow-up after 2 months later, hemoglobin ارتفع ووصل ل 11.2 gram per deciliter or 112 gram per liter, and she was reported to improve her symptoms. كل السيمبتومز اللي كانت بتشتكي بيها. And thus, after unsuccessful trial of oral iron, the initiation of intravenous iron therapy resulted in improvement of hemoglobin level. And although this is not sufficient alone, the use of intravenous iron to top up the patient with iron stores prior to starting ISA therapy is ensured that target of hemoglobin were achieved with the lowest possible ISA dose. يعني مهم قوي ان احنا نخلي بالنا لو وصلنا اللي هي التارجت بتاعنا بتاع الايرن ستورز وذ انترافينال حتى الايزا دوز هتبقى بعد كده هتبقى اقل. لو تابعنا العيان ده بعد شهرين بعد 3 بعد 4 ممكن الهيموجلوبين بتاعنا يوصل لاكثر من 12 او 13. في الحاله ديت ممكن نوقف خالص اللي هو الايزا ثيرابي، مش نقلل بس، ممكن نوقف الدوز بتاعته خالص. So, Mr. Chairman, I just came to my conclusion and take-home message. The iron deficiency is very common among patients with chronic kidney disease, and we monitor all chronic kidney disease for anemia and iron deficiency screening test of iron deficiency anemia, TSAT, and serum ferritin. The indicators for iron administration are based on the TSAT, ferritin, and some patients the hemoglobin percent. From the guidelines that I have mentioned, the iron is given in most of chronic kidney disease patients who have TSAT less than 20 or ferritin less than 100 or 200. Okay, and iron also given to most of the anemic patients with chronic kidney disease who have TSAT less than 30 or 500. This is according to many guidelines, actually, one KDIGO, others the KDOKI, like this actually, and this is to arrange for بهيئ العيان ان انا هو to receive the erythropoietin stimulating agent, either Evo alpha or beta or darbepoetin or whatever the formulation, or even the other newer agent of hypoxia-inducible factor. We do not treat iron deficient with TSAT more than 30%, since such patients are unlikely to respond to iron. We do not routinely administer the iron to patients with ferritin more than 500 and anemia, although such patients should be assessed individually. As I mentioned, individualization. مش معنى ذلك ان انا العيان ده عنده خلاص عدى، لا، لازم I have to just make further investigation to make sure the patient had really sufficient iron stores or he has not true iron deficiency. The timing of iron therapy initiation, route of administration, selection of treatment regimen should take into account a number of factors, including the severity of anemia, the treatment goals of chronic kidney disease, of anemia and chronic kidney disease, and dialysis mortality, comorbidities, concomitant patient health issues, as well as the relevant practical consideration. الاورال بريبريشن اللي احنا عارفينها ذا باي فار ذا موست كومن اللي احنا كنا بنستخدمه لفتره طويله ذا فيرس سلفيت ذا 325 and multiple intravenous agents are widely available موجودين وبكثره واسماء كثيره جدا في منهم موجود عندنا في مصر وفي still we are waiting to be approved in Egypt actually and for evidence the evidence based for the key DIGO guidelines recommendation particularly with respect to the use of intravenous versus oral iron in patients with chronic kidney disease non-dialysis was somewhat limited ولكن طبعا أنا أعتقد بالداتا الكتيرة اللي أنا وريتها إن إحنا ممكن still can use intravenous iron in patient non-dialysis chronic kidney disease patient. Thank you for your attention and I'm going to be more happy to receive your questions.
Thank you very much, Professor Dr. Kamal. It's very comprehensive, very illustrating, and as well illuminating. I think it's a reference now that your talk could be as a reference for all juniors, that can have the text to review themselves, as well for their information given. I would like just also to highlight that you are a co-chair of the Egyptian guidelines in anemia. So I would prefer that if you put one or two slides of your work in anemia management in Egyptian NICE.
I'm one of them, by the way.
Yeah. I understand that. So I was waiting till last slide your photo appearing in the Egyptian guidelines. But in general, the information given is for a long time that could be as a text for most of the juniors that can study as well for the anemia. And we now open the discussion and questions. I think Professor Yasser will handle that.
Yes, we have many questions on the chat, starting even from the first 10 minutes from the Professor Kamal lecture. First, from Abu Abdullah, how can we approach functional iron deficiency anemia and manage it practically?
تاني يا دكتور.
How can we approach functional iron deficiency and manage it practically?
Yeah, it's very important actually, a very important question just to differentiate between the true and relative iron deficiency. هو الحقيقة طبعا ده مهم قوي to differentiate between both. As I mentioned, the true iron deficiency anemia أحيانا احنا بنعمل روتين iron investigation أو iron profile serum iron serum ferritin ولكن أنا أعتقد إن الحاجات يعني transferrin saturation is more convenient and more sensitive test more than ferritin because ferritin is considered as one of the acute acid phase reactant and they may be increased with many issues. For example, infection is a scenario of HCV patient, for example, on hemodialysis. All patients of hemodialysis with HCV, if you measure ferritin, it will be very high. So to consider the approach, you first assess the serum iron, okay, after diagnosis of anemia, of course, and then if the iron is okay, I mean, it's not necessarily to be iron, it has sufficient iron stored to have TIBC just to assess the transferrin saturation or to go for ferritin. As I mentioned, it is maybe a very misleading as a ferritin as one of the indicators for iron stores in patients with chronic kidney disease anemia. So transferrin is considered as very one of the important. في حاجات تانية كتيرة جدا ممكن نعملها زي مثلا اللي هو reticulocytic hemoglobin content or الهايبوكروميك ريد سيل content percentage. الحاجات دي كلها طبعا هعتبرها مش نيو قوي ولكن ما زالت اعتقد ما هيش very widely I mean described او ان احنا requested as one of the tools for assessment or indication of anemia. الحقيقه ديت الحاجات اللي هي، ولكن طبعا عن بقى عملت انت البيشنت عمال بتصلح الايرن وعمال بتدي كل حاجه، ومع ذلك ستيل الايرن بيقع باستمرار او الهيموجلوبين بيقع. You have to think about iron loss from whatever either gastrointestinal blood loss or from other any source of bleeding. So source of bleeding or chronic iron loss has to be excluded, has to be rolled out. فالابسط حاجه على الاقل اللي هو الاوكالت بلاد في الستول in the stool, it's a very good indicator actually for chronic blood loss from gastrointestinal tract. طبعا
Dr. Kamal, what's your opinion? I memorized that more than 20 years ago, we are giving small dose of vitamin C for patients with functional iron anemia, as well for those, and I think I published one paper on that. There is improvement in 500 milligram vitamin C at the end of the session. There was a publication at that time as well, improving the anemia for such patients. What about today? We are using more permeable dialysis membranes and we don't check for vitamin C. And if you saw that, what's your recent information about giving small doses of vitamin C for patients typically with iron deficiency, functional iron deficiency anemia?
I agree with you 100%, Dr. Hisham, and we used to have that in the past, actually, even in this patient with high serum ferritin, actually, just to deliver or just to load those vitamin C to make the iron available, actually, in the to be available to stores, actually. وحاجة تانية مهمة كمان، ويمكن ديت من ضمن الحاجات اللي احنا يعني محتاجة مننا شغل برضو كتير. أنا myself I did publish some, it was like kind of thesis we published in a group for hepcidin in patients with chronic kidney disease, anemia, and we found that hepcidin is one of the very major obstacles for for iron therapy in patients with chronic kidney disease, anemia. You know, hepcidin, for obvious reason, it may kind of interiorization or like iron block. Iron B is going to be only available in intracellular, but it's being repleted. The other stores actually is being blocked inside the cells. So
raising the point of hepcidin here, and I think it's one of the big questions about hepcidin in anemia management and the role of dialysis technique in reducing the hepcidin, especially in hemodiafiltration. By the way, hepcidin is not a very big molecule. It's in the range below 5,000. But typically in hemodiafiltration, improving the inflammation, decreasing the hepcidin, besides its current removal on dialysis. So you got the two attacks of improving the anemia by removing cytokines and removing as well hepcidin efficiently in hemodiafiltration. Subsequently, lower doses of
I know that it's hepcidin is considered as a protein, basically, actually.
Yeah.
It's protein bound, and hemodiafiltration is one of the very important issues.
Improving, yes.
The very modalities to remove cytokines and hepcidin, of course, actually, one of these molecules to be removed on dialysis and improve anemia.
Okay, thank you very much. Next question, Professor Yasser.
Yes, Professor Ayman Rifai.
دكتور أيمن، أهلا دكتور أيمن، أهلا بيك يا فندم.
أهلا بيك دكتور كمال. Thank you very much. Very, very elegant and comprehensive overview. الحقيقة you covered all the aspects of anemia. But I have a comment about the other side of the coin. Actually, we are usually focused on monitoring of anemia rather than the other side, which is the iron overload, which actually it is not uncommon due to iatrogenic iron replacement. And as we know that the patient with CKD might suffer from sequelae of this iron overload, affecting major iron storage sites like the liver, iron overload due to substantial organ damage, even the liver causing liver failure, the cardiac causing
Pancreas also.
dysrhythmia, pancreas, diabetes, pituitary, thyroid,
cardiomyopathy.
يعني أنا
Yes.
الحقيقة أنا highlighted that issue. Actually, I didn't يعني just talk extensively about it, but I highlighted.
Okay.
يعني you have to be very careful
Yeah.
for that actually. Yeah.
Yes, the other thing that it's also could affect the immune system and increase the virulence of the some microorganisms and especially the virus and HIV, etc. What I want to highlight that we cannot rely on the serum ferritin in diagnosing the iron overload, as you know that it's influenced by several factors like the liver disease, inflammation, and so on. So so there is a recent publication this year raising this issue and give a more accurate alternative to ferritin, which is the doing the T2 MRI for these organs to diagnose iron overload.
Oh,
this
very
is
nice actually.
Yeah, this is
very nice.
My comment. Thank you, Professor Kamal. Thank you very much.
Thank you. No, thank you, Professor Ayman, for this very new. I mean, it is very, very innovative. Actually, it's an innovative method for detection of iron overload, as it does with many other other overloading.
It was also done, Professor Ayman, probably 25 years ago or 20 years ago in Wilson disease as well for the MRI diagnosis. So MRI can, yes. So it's one of the best tools that correctly to raise that MRI can diagnose a lot of depositions of metals in the liver or particularly in the skeletal system in general, in particular ferritin. I think it is a feasible and very good choice that we can go for MRI for diagnosis that and easy way.
Yes, and this was raised recently in.
It was raised in Wilson disease. Yes, before, but it's now it's okay for iron overload.
طبعا ده من ضمن الحاجات اللي هي برضه together with many other diseases also can be traced by MR. يعني as I was talking about MR, I was very recently I was discussing a thesis in Alexandria University. معلش يمكن it's away from iron a little bit, ولكن lupus activity and flare is being detected by the MR. So this is also another benefit of the MR for nephrology practice, basically.
And it's another way for radiology. Radiology now is in every step in nephrology. So
yes, MRI is very sensitive in diagnosing lupus cerebritis, Dr. Kamal. Lupus cerebritis is diagnosed. It's diagnosed by MRI.
Vasculitis, yes, sir.
Let me go before going again to the chat. I have an explanation, please, Professor Kamal, and correct me. You said that oral iron dose is 3 times per day. Oral iron, recommended oral iron is 3 times.
لا يعني هم ممكن تديهم 3 divided dose, one of them at the bedtime. ولو حبيت تديهم كمان كلهم at the bedtime will be better اكتر عشان طبعا to avoid المشاكل اللي هي ممكن تقابل على الاورال
I think 3 times per day would
basically
be
intestinal losses.
Yes. Okay.
انت المفروض انت محتاج 200 مللي جرام elemental iron يا دكتور ياسر.
Yes.
انت لو بتدي 1 تابلت ايرون سلفيت فور اكزامبل محتاج على الاقل 3 حبات في اليوم علشان توصل للثيرابيوتيك دوز اللي انت عاوزه.
Okay. We have another question from Dr. Abu Abdullah. Why we not have iron in dialysate solution in our units in Egypt?
Yes, that's my question.
دكتور هشام actually هو الحقيقه في فلترز موجود فيها ايرون اعتقد ان في
فيتامين اي. Looking in depth on that, what drug should be identified? The rules of the drug should be obeyed for the 5 rules. the right drug, the right dose, to the right patient, to the right time, and lastly, to the right route. So if you are defining these drugs and giving, you should obey all the rules of a drug. If you are giving that in a dilate, what is the dosage adjustment between low flux, high flux, or hemodiafiltration? What is the dilate penetrations from the iron stores in the dilate concentrate to the patient direct to the blood? You cannot control the dose. So you have failure in the dose route and dose control for individual patients. So I absolutely against that.
وده اللي انا دايما حضرتك تقوله لنا يا دكتور هشام اللي هو الانديفيدواليزيشن وبرضه لو احنا عملنا كده ان هو حاطين
you have an easy route and a controlled route to give by IV. That's especially sometimes you're giving a dialyzer filter with vitamin E coated. What is the benefit? It is just a marketing. It is not a beneficial for the patient.
هيحسن ال availability of iron to the stores and to the for the bone marrow
So your question, Dr. Abu Bakr, it is not the right route or the right dose to control exactly, especially iron as a toxicity. You cannot guarantee that the patient will not have iron toxicity.
Okay. Another question is from Dr. Nasser, hazards of iron if high blood pressure, and from Dr. Ghada Sobhi, should CRP be done to rule out infection before IV iron therapy or not?
السؤال الأول اللي هو for hypertension, I think there is no consensus or there is no data talking about iron and I mean hypertension. بل بالعكس كمان ده احنا الاستخدام بتاع الايرن ان هو بيحسن الانيميا وبيحسن بيقلل الكارديوفاسكولار diseases basically cardiovascular disease بيقلل الهوسبيتاليزيشن الكلام ده كله اعتقد ان احنا ما فيش داتا على الهايبرتنشن تحديدا ولكن من السياق ان هو بيقلل الكارديوفاسكولار morbidity and mortality. انا اعتقد استخدامه مع الهايبرتنشن is not and correct me if I'm wrong actually Dr. Yasser.
No, yes, exactly. There is no relation between blood pressure and
I think the question is conflicting with EPO. I think this is my
maybe with EPO of course
yes I think
كلنا احنا الإبو عند ليفل معين بيبقى طبعا associated with cardiovascular morbidity وده طبعا من داتا كتيره اتقالت قبل كده وده كمان احنا قلنا الايرن بيقلل الايبو ريكوايرمنت فده حاجه كويسه ان هو يعني نقدر نستخدمه سيف قوي مع كل العيانين بتوعنا اللي هم عندهم هايبرتنشن او اللي هم برون تو هاف كارديوفاسكولار ايفنتس. السؤال الثاني اعتقد في حاجه على
السي ار بي يوز اوف سي ار بي از
اوف كورس طبعا. هو السي ار بي از يعني هنقول ان هو ماركر لحاجات كتيره قوي الانفلاميشن للانفكشن لحاجات كتيره جدا ولكن طبعا از لونج از احنا بنتكلم على انفكشن يبقى لازم العيان ما يكونش طبعا we don't give iron to infected patients either has systemic or localized infection. فأنا أعتقد إن إحنا if you are right that we can just estimate one of the indicators for inflammation at least by CRB. هو طبعا CRB منهم في أنواع كتيرة قوي فلو هنستخدم high sensitive CRB أفضل.
Yes, and I think we should look to the patient as whole, as a CRP baby is conflicting somewhat in CKD patients. So we can look at the patient as whole as the source of infection, other markers, parameters of infection, TLC, procalcitonin, and something.
Yes, especially patient with current infection will not get a benefit from IVI because there is suppression of bone marrow. As well, it will affect the macrophage function and increasing the peroxidation, lipid peroxidation, and the other inflammatory. So I think we can hold IVI with current infection until controlled.
Okay.
Right.
Professor Faisal Shaheen, please.
Dr. Faisal, أهلا بك Dr. Faisal.
أهلا Prof. Kamal. I enjoyed your talk. Just only
Thank you very much.
Very simple question. Did you think that ESA have any role as a chelating agent for high ferritin, especially in the liver disease patient and CKD or post-kidney transplant?
Practical or guidelines? Practical.
Well, I think if someone already have very high ferritin,
Yeah, I myself, but I take it from some articles actually to use the chelating agent. Basically, the for ferritin, very high ferritin, to give one single dose after each hemodialysis for one month or so. It's just very beneficial actually. It will not harm the patient. So at least if you take the iron, this iron overload, you take it away, it will be very helpful and very beneficial for the patient. I just have heard.
I think, Professor Kamal, it depends on the hemoglobin. For example, if the patient with hemoglobin 13 and the ferritin is high, you cannot give ESA at that time. So it depends here. If the hemoglobin.
Dr. Faisal is asking about if there is, deposition in somewhere. It has been deposited in the liver, in the.
But the risk of ESA at that time, if the hemoglobin is more than 12 for patients with transplant, for example, if you are giving ESA, the risk of ESA is higher than the chelator effect or decreasing effect of serum ferritin. So you have to balance between risk and benefit.
Right.
I agree with you.
Faisal, can you give us your experience in this?
Yes. Well, I have few patients actually, and I don't have, as a guide or a recommendation, but I think still we can use ESA in some of those few patients, because we don't, either we give desferrixamine or we give ESA. Which one is better? If he had anemia, it would be good to give erythropoietin, and if you don't have anemia, probably you have to go for desferrixamine.
Did you test Professor Faisal, the vitamin C? Did you think about giving small dose, 500 milligrams per day, and it's safe in patients?
I got you, Dr. Faisal. Actually, this is very. Instead of just taking this ferroxamine and this other chelating agent, why don't you was just able to consume this iron overload?
Yes.
So that I've got
Okay, another question from
Dr.
Yes, Doctor. Thank you, professors. Another question from Dr. Fatma Zahra. If you, dear professors, if you please guide us for best iron products in the market suitable for dialysis patient allergic to iron sucrose and iron extran, and of course of iron deficiency.
Well, again, we are talking about the individualization, the availability, okay, and كل حاجة لازم نحطها في الاعتبار، وحتى يمكن ركزت على ده. الافيلابيلتي في الماركت الموجود من كانتري تو اذر. الحاجه الثانيه الكوست مهمه، الكوست بارير مهم جدا، وعلاوه على كده طبعا الاكسبيرينس. وفي معينه زي ديكستران از ويل نون، معروف ان هو من ضمن الحاجات الادويه اللي هي فيري مش هنقول باد، ولكن هي دي اللي كانت موجوده في وقت معين وكانت كويسه خالص وكانت شغاله كويس جدا، ولكن مشكلتها الكبيره قوي ان هي بتعمل اللي هي الهايبر سنسيتيفيتي and anaphylactoid reaction. So we have to be very careful for that. If we are just overriding this issue اللي هو of hypersensitivity وعدناه البيشنت ما عندوش hypersensitivity we can give the dose. ولكن طبعا للاحتياط يعني for unconscious issue ان احنا طبعا to go for the other non-dangerous one like iron sucrose اللي موجوده كتيره قوي، موجوده عندنا في الماركت، موجوده في مصر. والدوز بتاعتنا طبعا زي ما احنا قلنا ان هم ال 1000 مللي جرام يديهم على 5 سيشن ولا حاجه، وعلى 1 ويك اور 2 ويكس، تمام، عشان تو افويد برضه اللي هي البوسيبل هارمفول افكتس اللي ممكن تحصل. طبعا لو احنا افيلابل عندنا وموجود عندنا ذا نيور ايجنت زي اللي هو الفيريك كاربوكسي مالتوز، ده طبعا من الانواع اللي هي الجديده، واعتقد الدكتور فيصل مش عارف اذا كان افيلابل في السعوديه عربيه او نوت. ده برضه من الحاجات الكويسه قوي، ان هو الميزه الكويسه فيه اللي هو الكونفينينس، ان انت ممكن تدي سنجل دوز تبقى تكفي، وتدي تريبليت او تريبلينش ذا ايرن ستور والسنجل دوز سيميلرلي وذ ذا اذر وان. الفورموكسيتول برضه نفس الكلام. ديت اللي هي الميزه بتاعت ذيس نيور ستيبل ايجنت اكشولي، اللي هي الديسوشيشن بتاعها بيبقى صعب شويه، عشان كده بتفضل في الستورز اطول فتره ممكنه، واطول فتره ممكن المريض يستفيد بيها. وغير كده كمان اطول فتره to make the iron available to be used or not to be consumed by the red cells for to enhance the response to erythropoietin.
Professor Faisal, do you have a comment about the availability?
استخدام الavailable.
Yes, we have Ferro inject, which can be given 2 doses, and also, you know, everyone is using Ferrosac also, most of the patients. But Ferrojet is excellent as outpatient 2 times or 1 time even, which is quite good.
هو الكلام على اللي هو النون دايليسيس يا دكتوره، انت بتتكلمي عن النون دايليسيس ولا الدايليسيس؟ لو الدايليسيس يبقى احنا نديهم على 2 ويكس اللي هي الايرن اللي احنا عاوزينه، او لو النون دايليسيس بقى طبعا الوضع يختلف ان هو مش على دايليسيس.
Yes, stage 4 or
3 or 4. 3 to 5.
Really very interesting, fruitful, and comprehensive discussion, and I advise all the audiences to follow up the discussion strictly as much as the lecture, as we have here 2 questions about the iron overload from Dr. Wali and about the use of vitamin C and role of treatment, and we have discussed these issues early in the discussion points. Professor Kamal and Professor Hisham, I think.
اتكلمنا عليهم طبعا، ولكن to follow up the TSAT and to follow up the ferritin. ولكن قلنا ان الفيرتين طبعا ممكن يكون very high for another issues، ولكن ال TSAT is exceeding 30 or 50. طبعا نخلي بالنا at this time it's considered as some sort of iron overload. في الحالة دي طبعا we will re-monitor the patient again for the iron stores. احنا هنوقف الايرن اللي احنا بنديه ونمونيتور بعد 1 or 2 weeks ونشوف الوضع هيبقى ايه.
Okay, thank you. A question from Dr. Ahmed Fenawi. I think Professor Hisham will add to it. Can I depend on hemoglobin reading on dialysis machine or hemoscan for follow-up of anemia in comparison to lab results, or not accurate?
No, sir. You cannot compare that accurately, because the hemoscan and the other depending on falsely the hematocrit concentration against the ultrafiltration. So it is not designed for a lab, it is designed for controlled ultrafiltration depending on the hemoconcentration effect of ultrafiltration. You have to do on a midweek pre-dialysis hemoglobin level at least once monthly. So this is in terms of controlling the hemoglobin, midweek session, pre-dialysis at least once monthly, or even more frequent if you are adjusting the doses of ESA, you can do it by 2 weeks period.
Midweek pre-dialysis testing.
Yes, exactly.
Professor Saeed Khamis.
دكتور سعيد.
السلام عليكم دكتور كمال.
الأول الحقيقة طبعا يعني I'd like to thank my dear professor Dr. Saeed. He just helped me with one slide actually from this. وشكرا جزيلا لك يا دكتور سعيد. طبعا يعني he's
always behind the screen, Professor Saeed.
شكرا دكتور سعيد. اتفضل حبيبي.
You're welcome, Professor Kamal. Thank you for this. Professors. Just I have 2 comments, if you allow me. Number 1, regarding the side effect of IVI, as all raised on this, and Dr. Ayman said, too much is not good, too little is not good. But iron lead to, in some cases,
Doctor.
To what's called hypophosphatemia. This hypophosphatemia.
Dr. Saeed, your question is not clear. Your voice is interrupted. You have a bad connection. Did you get it, Dr. Kamal?
You hear me now?
أنا سمعتها hypophosphatemia.
يعني was interrupted. احنا سمعناها كلنا مقطعة كده. Can you repeat it please?
Do you hear me, Professor Yasser?
No, it's not clear. It's still not clear.
Okay, I will.
Yes.
I will move.
started to be clear.
ممكن تقولها اسمعك في التليفون واقولها لزملائنا دكتور سعيد.
you can hear, I think. Hear me now, Prof.
It is better now. It is better. أحسن كده. كده أحسن كتير.
Okay, number one, hypophosphatemia, especially with the new generation like maltose and even with iron screw. So we should pay attention to this complication or side effect. Number two, also the long-term use of IV iron can lead to high anion gap metabolic acidosis. If you remember this acronym of mud biles, this I is for INH and also for iron. So it can lead to high anion gap metabolic acidosis. Second, the oral iron and the drug interaction with oral iron, as Professor Hisham mentioned at the beginning of this meeting regarding the hypothyroid patient, oral iron markedly interfere with the L-tyroxine absorption. So we should be careful to give the L-tyroxine at least after iron, away from the iron, the oral iron. Lastly, regarding the question of Dr. Ghada, to cut it short regarding to give iron with infection or not, it is categorized into three categories. Also, there are no clear guidelines for this, but it's a matter of confidence. Number one, you can give iron safely in the following situation: if there is no signs of infection. Number two, if isolated increase in CRB, it's a contraindication. If HIV with suppression, drug suppression, stable and chronic use of steroid, latent TB, minor. Second, you consider hold plus minus if there is moderate localized infection like bronchitis or H. pylori under treatment. But should stop or we should not give iron if the patient has sepsis or bacteremia or severe localized infection or active TB. So at least 2 weeks should be passed after complete cure from this severe infection to give IV iron if applicable. And thank you so much.
Thank you, Dr. Saeed, for this elegant comments, actually, and it's really appreciated.
We have a question from Dr. Abdullah Al-Bajir. Can we add iron transfusion for patients with normal hemoglobin level but low ferritin and TSAT, and of course low serum iron?
Yes, yeah, I think yes, because iron deficiency is not on a hematological point of view. Iron deficiency as well can affect the mucosa, can affect the cell function. So it's one time that if you have a level of iron that in the normal range, you get a vitally healthy cells, mucosa, even if the hematological, and we all know that you can have an iron deficiency still with the normal hemoglobin, but still there is lower iron in the red blood cells, and subsequently, lately, you have an anemia. So to my opinion, I think that yes, we can give, and it's mandatory to give iron in patients with even iron deficiency without anemia.
I agree with you, dear Professor Hisham, actually, and that's what we call it actually iron deficiency complex, not anemia. It's
exactly.
And involved in any tissues, in the epidermis of the skin, hair. It affects the vitality, the memorization and everything, fatigue and all this. It's called
mucosa, tongue affection, yes.
So the patient, if he's has kind of true iron deficiency, regardless anemia, then we can give iron preparation. Yeah. Dr. طارق منور.
نورك حبيبي، نورك حبيبي. السلام عليكم. السلام عليكم. Many thanks, Professor Kamal, Professor Hisham, Professor Yasser, all colleagues. You give us an elegant presentation, and I'm very happy from that discussion that enriched the subject. I would like to add only to avoid intramuscular injection of iron, especially in our CKD populations. As regard iron dextran, I think the Professor Kamal the rapid repetition from iron dextran, actually with the high molecular weight iron dextran, because recently we use low molecular weight iron dextran by the name Cosmofair with less side effects. Of course, as you mentioned in your lectures, we have to do a test dose for all. But I am with the usage of low molecular weight iron dextran because it gives the privilege of total parenteral infusion, and I can replenish the iron stores within a few sessions. As regard iron saccharose, I am limited to, as you mentioned also in your presentation, maximum dose per session around 200 milligrams. Many thanks for that fruitful night, and actually I am sure that all nephrologists put in mind that we cannot to proceed to epotherapy without replenishing iron stores, or to give epotherapy in the presence of iron deficiency.
It's wasting money. Wasting money. Let me ask you, Professor Tariq, how many of us inspect, again, how many of us inspect the injection site of intramuscular iron, and you can find the horrible.
Yes.
No one of us inspects after giving the iron, how is the injection doing in the patient?
Actually, I face it in our colleagues in internal medicines and some nephrologists. They give it in an easy way for instead of intravenous, as mentioned by Professor Kamal. Oral iron give a lot of side effects, gastrointestinal upset and flatulence and some sort of disturbances. So some physician prescribe it intramuscularly. Actually, we saw a lot of complications from that way. Yes.
This is the point.
That's big bad tattoo.
Yes, sir.
Last question in the chat from our coordinator. Last question in the chat.
You will never forget it, yeah.
Yes.
بتفق معاك تماما دكتور طارق. Thank you very much for raising this issue again of high versus low molecular weight dextran. And I'm very happy actually that you are following my lecture. And that issue basically is that if we want to use dextran, but whatever the nature, high or low molecular weight, have to do test dose. The patient is negative, then we can give 1,000 milligram intravenous in a single sitting. So this is actually what I was talking about when comparing to the other newer expensive agent. If we have such a medication like this and the patient is not allergic to, so this is another way to make the patient to cover the patient convenience actually for to come to the hospital and come back like this, especially for non-dialysis patients.
Yes.
I think now we are in the end of this session. It's a midnight. We are enjoying. We enjoyed. Yes.
But we have two questions on the chat. The audience, all of this is made for the audiences. So we have a question. One is for have been discussed for alternatives of iron dextran in sucrose for allergic patient, and the last question from our coordinator today, Abdurrahman Maghrabi. What about using lactoferrin with oral iron, and what about recommendation? Yes. And what about the recommendations to use oral iron? I think we are to do about Pravotine in addition to oral iron. He's asking also about oral iron every other day rather than daily dosage. Do you have a recommendation for this, Professor Kamal? And about the use of lactoferrin?
There is no recommendation for that, and this newer agent actually had the reputation الكبيرة بتاعتها قوي during the era of COVID actually. This lactoferrin and the other preparations, but it's been heme iron preparation actually is a good choice and another alternative for ferrous sulfate and other oral formulation. for their efficacy and the absorption and the response to therapy and response in terms of improving the hemoglobin level. So one of these iron preparation, okay, I'm not going to talk about commercial issues actually, but it may improve and increase the hemoglobin by 1 gram every month. So I think some of the oral preparation in terms of the lactoferrin or heat iron preparations actually are very effective and very beneficial in patients with chronic kidney disease, non-dialysis patients.
But the hematologists usually use this preparation nowadays. Many hematologists use preparation iron deficiency extensively.
Yeah, they use it actually for pregnancy, during pregnancy even, yeah.
So as you said, Professor Hisham, we are going to suhoor now and no more comments and more questions on the chat.
It's enjoyable up to the Zoom, but I think we are expanding more than 2 hours, so we can extend the talk up to another 2 hours without any misses. But it's a time to say goodbye, everyone. We are enjoying really the meeting, discussion, eminent professor, pioneer speaker, and for course, our star, Professor Yasser Abdel Hamid, is the active machine in the CME. Thank you very much, and wishing you all good suhoor and see you soon. Thank you very much.
And thank you all.
Very much. Thank you very much all. And
we are honored to have you
ما
today.
تزعلوش مني لو كنت طولت عليكم شوية، بس طبعا يعني هو challenge الحقيقة. When I hope that I covered it all on all kind of patient like non-dialysis, dialysis, chronic kidney disease patient. Thank you all, and I hope it was fruitful. Yeah, I hope
very fruitful.
One of the most enjoyable. One of the most enjoyable. Thank you, Professor.
Thank you very much,
Hisham.
all dear Professor, Dr. Hisham, Dr. Yasser, Dr. Tariq, Dr. Saeed, and I can see Dr. Samir Kamal also, Dr. Ayman. Thank you all my professors.
شكرا جزيلا دكتور.
شكرا على خير إن شاء الله.
Thank you all professors for attending.
كل سنة وانتم طيبين وجو فور سحور.
Excuse me to close. Excuse me to close. Thank you, Professor Kamal, for this highly elegant lecture. And Professor Hisham.
Thank you.
And all attending professors, Professor Ayman Rifai, Professor Tariq Tantawi, Saeed Khamis, Professor Samir Kamal, Professor Faisal Shaheen. One of the most enjoyable meetings of ESMT CME meetings, and announce about the coming meeting about how new weapons in treating proteinuria by Professor Tariq El-Baz will be. I think we will enjoy it to the max next Wednesday. Please don't be late. Next Wednesday, 10 p.m. inshallah. Thank you very much.
Inshallah.
Wassalamu alaikum wa rahmatullahi wa barakatuh.
وعليكم السلام ورحمة الله وبركاته.
شكرا جزيلا.